Hello, friends. Good evening. Today I'll be talking on this topic, fibrinogen concentrate in ICU. Wish to acknowledge my colleague, Dr. Pradeep, who helped me develop this content. So, we had a inter-Manipal hospital meet where we had doctors from all Manipal hospitals in Bangalore who wanted to understand this molecule, fibrinogen concentrate, which is available in a synthetic form. And to have clarity from our ICU perspective on its role and what is the evidence that is currently prevailing with regards to usage of this fibrinogen concentrate in various conditions. So this was the deliberation we had with an overview on this topic, followed by our own experience of cases where we use this fibrinogen concentrate, and we had a panel with all our Manipal doctors in Bangalore. So I'll just take you through. It's very useful for all the trainees to understand what is the current standing of this particular molecule in ICU armamentarium. So fibrinogen, as you know, it's a factor 1. You have 1 to 13 clotting factors. So fibrinogen is factor 1, which is a 340 kilodaltons plasma glycoprotein, which is synthesized in the liver. And why do we need it? Fibrinogen, as the name sounds, it is needed and it is useful for the formation of the clot. And as you see, all the small thin strands, what you see is all the fibrin that is there. And you need fibrinogen for the production of this fibrin, which helps in aggregation of the platelets and the clot formation. So that is the role of fibrinogen in a simplistic way. So as I said, we have factor 1 to 13 in our body. And amongst these, the maximum concentration is of factor 1, which is the fibrinogen. And just to understand this molecule, the half-life of this is around 3 to 4 days. And the minimum level that one would expect to be in the body to attain hemostasis is 100 milligram per deciliter. So that is the minimum concentration that is required in the body for some sort of a hemostasis to happen. So now trying to understand what are the sources of fibrinogen. So traditionally, all intensivists, we like to use FFP when there is bleeding. But if you are using FFP with a thought in mind that you'll be replacing fibrinogen, it is not an ideal source. So this is something we have to be very clear in mind, because the amount of fibrinogen in FFP is only 1 to 3 milligram per ml, which is a very small quantity. So the ideal source of fibrinogen for us, if you are wishing to replenish, is cryoprecipitate. And how is cryoprecipitate produced? It is produced by thawing. So one would thaw the FFP, and it is a derivative from the FFP. We create the cryoprecipitate because cryoprecipitate is rich in fibrinogen. So it has fibrinogen. So this is just the molecular structure of fibrinogen. I put it. So whenever you see this picture in my presentation, it's fibrinogen. So you have fibrinogen in this. Then you have, along with fibrinogen, factor 8 and factor 13. Then there is also fibronectin. And most interestingly, the cryoprecipitate also has von Willebrand factor. So these are the constituents of cryoprecipitate, which I think every trainee should have clarity on. When you administer cryoprecipitate, you are administering more of fibrinogen, 8, 13, fibronectin, and von Willebrand factors. And this is also very important. If we give 1 unit of cryoprecipitate, it increases fibrinogen by 7 to 10 milligram per deciliter. Okay, so if you have to increase by, say, 100 mg per deciliter, then you have to give 7 units. So you can remember that 1 unit is up to 7 to 10 milligram per deciliter rise in the fibrinogen levels. And the normal dosage of cryoprecipitate as referenced in literature is 1 unit for every 5 kgs. If you want to go per kg administration of cryoprecipitate, it is 1 unit per 5 kgs. So the easiest way to remember is this way, 7 to 10 milligram per deciliter for every unit is a better way. So, or you can remember as 1 unit per 5 kg. And what is the advantage? So before giving cryoprecipitate, obviously there are few things one has to do. One has to do ABO compatibility, which is needed because it's a blood product, and thawing is needed. So why I'm focusing on this? These are some of the things which you can bypass when you use synthetic fibrinogen, which is fibrinogen concentrate. So you need to do thawing when it comes cold. You have to get it back to room temperature while administering. So thawing is needed when you have to administer cryoprecipitate. And of course, because it's a blood product, there is a risk of transmitting infections. So it can be viruses, so on and so forth. So that risk will potentially always remain. And of course, because when you're using cryoprecipitate, so when you have to increase by 1 gram, you would be using 7 to 10 units of cryoprecipitate, which will enormously add to the volume of the body. And in ICU, we know how precarious is the fluid balance. So it does lead to TACO or TRALI. So transfusion associated cardiac overload, fluid overload is something that tends to happen with more volume. So these are some of the disadvantages you could cite of giving lot of blood products, which I'm sure all of us are aware. When you are activated massive transfusion, all this adds on to the volume. So these are some of the things which you can possibly negate with the use of synthetic fibrinogen. So the fibrinogen concentrate, which is a recombinant synthetic fibrinogen, which is available in the markets today, are available as a lyophilized powder. And it has to be diluted in 20 ml water, sterile water, and administered. So you will save. So what are the advantages? So all the key prerequisites that you need to follow is something that is not ABO compatibility issue is not there when you're using. There is no need for thawing, and there is no risk of transmitting infections, and there is no risk of causing volume overload. So these are some of the distinct advantages when you use this fibrinogen concentrate. And for us to just understand, so what is the mechanism of action or location of action of fibrinogen? So this is useful for all the trainees. So as I said, this is how the molecular structure of fibrinogen looks. So fibrinogen binds to glycoprotein 2B and 3A receptors on the platelet. So the green one is the platelet. So it binds to the glycoprotein 2B, 3A of the platelets. And in the presence of thrombin 2A and in the presence of 13A, which is a fibrin stabilizing factor, and in the calcium, leads to the clot formation. So this is the mechanism of action of fibrinogen. So fibrinogen binds to platelets, and in the presence of thrombin and 13A and calcium, it helps in formation of the clot. So this is what I think all trainees can have a bit of clarity. So this is how it mechanism. And by doing this, it helps in the clot formation, it helps in amplification of the clot, and it gives strength to the clot. So this is the three-way sort of an advantage or the benefit or mechanism of fibrinogen. It helps in the clot formation, it strengthens the clot, and it amplifies the clot formation. So now looking at the indications. So where all we can use this fibrinogen, or where all which are all the typical indications in ICU where we get to use this fibrinogen. So I've divided into 5 categories. So one is there are certain deficiencies where innately there is congenital fibrinogen deficiency, or there can be acquired fibrinogen deficiency, and this can lead to a lot of hemorrhages. And optimal level we would expect is 150 to 200 milligram per deciliter of fibrinogen is needed to prevent. So when there is hemorrhage, you need to maintain levels above this. And even for the wound healing, the minimum amount of fibrinogen that is expected is 50 milligram per deciliter. So these are some of the situations where one may have to consider using cryoprecipitate or synthetic fibrinogen where there is congenital or acquired fibrinogen deficiency. So this may not be necessarily been seen very often in ICU, but what we see in ICU is DIC, disseminated intravascular coagulation. So this is a situation where all the bloodlines come down, where platelets are down, you have coagulopathy, so and where you have fibrinolysis. So here you may have to give red blood cells, FFP, and platelets together. And here the fibrinogen target should be more than 100 milligram per deciliter. This is in DIC. And the third common situation we see is a postpartum hemorrhage. And it is reference that in the third trimester, the minimum amount of fibrinogen that is present is around 500 milligram per deciliter. And if this falls below, at least you need 40 to 50% of this level to attain hemostasis when there is a postpartum hemorrhage. So 500 milligram per deciliter is the sort of a levels of fibrinogen that are there in third trimester. And if there is at least 40 to 50% of this is expected, which means 250 and above should be there. So if it is below that, then the hemostasis will not be attained in postpartum hemorrhage. And the fourth sort of a typical clinical scenario where we see is liver transplant patients or liver failure, where there is reduced in the fibrinogen levels in the blood. Along with this, in liver failure patients, there is increase in the sialic acid, which helps in or which worsens the clot formation. So which delays the whole clot formation. And this is another spectrum of patients where there may be a need for cryoprecipitate or fibrinogen concentrate, especially when they have bleeding. And the fifth sort of a condition is the post cardiac surgery, where pre-op fibrinogen is low, they can have increased bleeding, and there are studies done to see if optimization of the pre-op fibrinogen helps in mitigating the hemorrhage in the post cardiac surgical setting. So here, as I said, the DIC is the clinical studies done in DIC is in the context of trauma patients. So look at the DIC in the setting of trauma patients. So I'm not talking about sepsis DIC, it's more of trauma-related DIC where they have done studies using cryoprecipitate and fibrinogen concentrate. So for all the trainees, so these are the clinical situations where one could think of using either cryoprecipitate or fibrinogen concentrate. And we'll show you the clinical studies. So in case of massive trauma, studies have shown low fibrinogen obviously has a bearing on increasing the mortality. And they have shown that replenishing this fibrinogen with cryoprecipitate has shown to improve the survival. And the 2019 European guideline on the management of major bleeding and coagulopathy following trauma, they have shown that if fibrinogen levels in trauma falls less than 1.5 grams per deciliter, which is recognized by either TEG or ROTEM, so 3 to 4 grams of fibrinogen concentrate as a replacement or replenishment has been suggested or advocated in this particular guideline that came in 2019. And of course, we look into the studies. So here there is I need to mention in all the clinical studies that they have done on the use of this fibrinogen concentrate, so they have utilized point of care testing to determine as to the group of patients who would need fibrinogen concentrate. Either they use TEG or ROTEM. Because of why I'm emphasizing is this, many ICUs we may not be using TEG. We would be depending on conventional coagulation profile, but all the clinical studies have utilized the point of care testing, which is TEG and ROTEM, to ascertain and determine what is the coagulation factors that may be deficient to determine whether there is a need for fibrinogen concentrate. So that is something. So I'm sure people, so this talk is not on TEG. So if you are cognizant of the TEG format, so there is a distinctive pattern which shows there is a low fibrinogen level. So if you see this pattern, then you would know that patient is low on fibrinogen, and it becomes an indication for giving fibrinogen concentrate. So I'll just make a brief mention and do a separate video on detailing the interpretation of TEG and ROTEM. So when you do a TEG, so you get a curve something like this where you have different formats. So what all our trainees need to look at is the arc time. So arc time is the time taken for the clot formation, and it is about 5 minutes. And if it is much beyond 5 minutes, then the choice of blood product is FFP if arc time is prolonged. So the K time, which is this, as you see, which is shown in the graph, K time determines the strength of the clot. So that is 1 to 3 minutes, and if that is prolonged, the choice of blood product would be cryoprecipitate. Okay. And this is the angle of clot polymerization, which has to be 53 to 72 degree, and it is the speed of fibrin formation. And if this is perturbed or there is aberration in this angle, then the therapy of choice would be fibrinogen with cryoprecipitate. So these are the distinctive forms of components of the TEG, which possibly one should bear in mind. And of course, this part of the curve shows the fibrinolysis. So these are so if the R time is prolonged, then FFP. So if the K time is prolonged, then it will be cryoprecipitate. If the angle of this is prolonged for whatever reason, the speed of clot formation is affected, then one has to consider cryoprecipitate. So as an understanding, conceptual understanding, keep this in mind. So this is a ROTEM. So ROTEM and TEG are little different. So not many centers have ROTEM. So our center, Manipal Hospital, we have TEG. We use the TEG. But ROTEM is an expensive machine. So there is technical differences. Even in ROTEM, you see a similar format. As you see in the ROTEM, CT is the clot time, CFT is the clot formation time. So A10 is the time, 10 minutes after the clot formation is the strength of the clot they look at, that is A10. And just focus on MCF, which is maximal clot firmness. Why I'm talking on all this is, all the clinical studies done to uh, decipher the role of fibrinogen concentrate have been done using this ROTEM or TEC. So that's why I'm focusing on this. And they have used these values. So maximal clot firmness is MCF, and this is angle of clot polymerizing index, and ML is the maximum clot lysis, and CL is the clot lysis index at 30 minutes, and CLI 60 is the clot lysis index at 60 minutes. So in ROTEM, it's very simple, don't get confused. We call it as INTEM. INTEM is TEM is ROTEM. INTEM is the pattern which recognizes the intrinsic pathway. It is similar to APT. And XTEM is, TEM is ROTEM, XTEM is the pattern which is indicative of extrinsic pathway, which is analogous or which is similar to prothrombin time. And there is FIPTEM, which assesses the fibrinogen assay, and that is similar, that basically ascertains your fibrinogen assay. So INTEM is APTT, XTEM is PT, FIPTEM is fibrinogen. I have wrongly put as APTT, FIPTEM is fibrinogen assay. So this is in very summarily, very in a crisp way, I'm telling how the ROTEM is interpreted. Why I'm mentioning is all the studies are based on these values to see, because they have used these cutoff values to replenish the fibrinogen concentrate and see its effect. So when we talk about fibrinogen concentrate, so the dosage is generally the dosage for adult is 2 to 4 grams IV. But for all the trainees, just remember it is 70 milligram per kg. So that is the dose that is sort of recommended for any bleeding patient. So fibrinogen level is known, then it is 70 milligram per kg. If you want to precisely calculate the dose of fibrinogen concentrate, then this is the formula. You need to take the target fibrinogen minus the measured fibrinogen divided by a constant which is 0.017. Very easy formula to remember. So just I'm giving an example. So if you want the target fibrinogen at 2.5 grams per liter, just minus by minus 1 divided by 0.016, you'll get 88.25 milligram per kg. So that is the amount of fibrinogen concentrate. So for all the practical purpose, just remember 70 milligram per kg is the fibrinogen concentrate you can use for any bleeding patient in ICU. But if you want to precisely calculate, you need to remember this formula. For 70 kgs, it comes to 6 grams, because each vial contains 1 gram. So you can give 6 grams. If it is 70 milligram for 60 kg, it will come to around 4 grams. Okay, so just remember that. And this fibrinogen concentrate, as I said, it's available in a vial as a lyophilized powder, should be stored at 2 to 8 degree, and it has to be used within 8 hours of reconstitution as a slow push, 2 to 3 minutes. And when you're pushing, the key important thing the nurses have to be told is to not to draw the blood. Because if you draw the blood with a fibrinogen concentrate, then clot formation happens in the syringe. So the key thing is not to draw the blood when you're administered. It has to be directly pushed, like any other antibiotics you would draw and see if the line is patent and then push. That should not be done in any of these sort of drugs. So I'm sure that most of you would be aware. So that's in brief about fibrinogen concentrate, how it acts, and mechanism of action. And I told you about the way we would calculate the dose, and in ICUs, most of you would act upon, we'll do a coagulation profile, we look at the fibrinogen levels. If fibrinogen level is low, then we give cryoprecipitate or fibrinogen. But all this takes longer time, because I'm sure every listener would know, once you send a coagulation profile, it will take at least 2 to 3 hours to get the reports. That's why most clinical studies have utilized TEG. And TEG, you see that pattern, or ROTEM. You look at the INTEM assay, XTEM assay, and FIPTEM assay. If FIPTEM assay tells you fibrinogen levels are low, then they administer fibrinogen. So that's all you have to remember. Anyway, I'll do a separate video on TEG and the ROTEM assessment. So let's look into the evidence. So this was the study which came, this is a very new study which came in 2023 called the FIEST study. As you see, the title of the study is Fibrinogen Early in Severe Trauma from an Australian multi-center randomized controlled trial. So here they took all the trauma patients and they compared fibrinogen concentrate versus the cryoprecipitate, because both are the same. Cryoprecipitate also has highest amount of fibrinogen. And the primary outcome is they looked at time to fibrinogen replacement. This is very important. Why they looked at time to fibrinogen is because if you have to order cryoprecipitate, it takes time for ABO compatibility, thawing. So, but with regards to fibrinogen concentrate, you can save on the time. So that was the hypothesis they had. Secondary outcome, they looked at fibrinogen levels. And the clinical outcome, they looked at the amount of blood that was needed in both groups and the mortality. So good study done in trauma patients. When you look at the results, so they had 62 patients, 37 in the fibrinogen concentrate group, 25 in the cryoprecipitate group. If you look, the median time of administration, so which means quickly you can resuscitate and correct the fibrinogen levels with fibrinogen concentrate, which happened at 29 minutes, as opposed to cryoprecipitate, which needed 60 minutes. So that was statistically. So you can correct the fibrinogen levels much early on, because you don't need to do ABO compatibility, you don't need to do the thawing, so on and so forth. And the dosage, the median dosage they used is 3 grams. As I said, 4 grams is the sort of a dose that you need to keep in mind. And cryo, they used 8 units, and interquartile range was 8 to 14. And the restoration of fibrinogen levels were similar. Either you use cryo or fibrinogen concentrate. Both were successful in replenishing the fibrinogen. And they looked at the amount of blood and fluids that was needed. That was also similar in fibrinogen concentrate. So the only positive findings in this was the time taken for replenishing fibrinogen was much quicker in the PST study. That was one study. So this study came in 2022, again in trauma patients from the US group. Fibrinogen supplementation for the trauma patients. Should you choose fibrinogen concentrate over cryoprecipitate? This was a 2 years retrospective cohort analysis. They took from the Trauma Quality Initiative database, and the excluding criteria, they excluded all the cirrhotics and the bleeding disorders, and patients who are on anticoagulants, they excluded. The outcome was to look at the amount of blood the patient received, ICU and hospital length of stay, and the mortality. So these are the typical outcome any study would see. And they looked at major complications. So in this study, the median age of the patients, trauma was 41 plus or minus 19, 74% were males, and the median injury severity score was 26. So they had 255 patients. As you see, 85 patients were in fibrinogen concentrate, 170 were in cryoprecipitate. So the blood, the amount of blood needed was significantly less in the fibrinogen concentrate group. Blood, FFP, and the platelet need was less in fibrinogen concentrate, and ICU and hospital length of stay also was less in fibrinogen concentrate. But mortality, there was no difference between cryo and fibrinogen concentrate. So again, a positive study. So the Australian study showed the time taken for administration was less. Here, the blood product need was less, and the ICU and hospital length of stay also was less, but mortality, there was no difference. So that's about the trauma. So we had some body of evidence in trauma. How about cardiac surgery? This was the study that came in, I think it was JAMA 2022. So this was from the Canadian group, which was called the FIBRS randomized clinical trial. Effect of fibrinogen concentrate versus cryo on the blood component after cardiac surgery. So the inclusion criteria was patients with cardiac surgery who had low fibrinogen levels and who had increased bleeding. Here they compared 4 grams of fibrinogen given over 10 minutes in 24 hours versus 10 units of cryoprecipitate in 24 hours. Okay, because as I said, you need 5 to 7 units of cryoprecipitate to raise 1 gram of fibrinogen. Here they used 10 units in 24 hours. So they had 735 patients, 517 patients were male, median age was 64 years. Primary outcome was to look at the amount of blood needed in 24 hours. So they had 735 patients, 372 in fibrinogen group and 363 in the cryoprecipitate group. And the amount of blood needed in fibrinogen concentrate was non-inferior. So basically this study was a non-inferior study. Basically it said instead of cryo in post-cardiac surgery who have low fibrinogen and increased bleed, you can use fibrinogen concentrate as opposed to using cryoprecipitate, and both had the same effect. So it was a non-inferior study. So this was also can be considered as a reasonably convincing study to tell us that you can utilize fibrinogen concentrate. So now we'll move to liver transplant, because I'm sure all the intensivists, you would be working in the liver transplant units. So liver transplant is a very complex scenario where there are multifactorial hemostatic disorders that tend to prevail in these sort of patients. So the liver patients have pre-existing coagulopathies, they have hyperfibrinolysis, they have hemodilution, they have consumptive coagulopathy, there is loss of coagulation factors, and there may be inadequate sort of a resource of the blood to be given to these patients because they need a lot of blood transfusion products sometimes. So availability can be an issue. So it's a complex perioperative coagulopathy that tends to prevail in these liver transplant patients. And there are certain studies. So Carrier et al. Has shown that in patients who undergo liver transplant, fibrinogen levels less than 3 grams preoperatively was correlative with increased risk of bleeding. And they showed that if pre-op fibrinogen levels is less than 1.5 to 2 grams, this bleeding can be mitigated by administering fibrinogen concentrate. So for this, they came out with this in liver transplant patients. They came out with a Gorlinger algorithm. So that's why I spoke about ROTEM. So in Gorlinger algorithms, they looked at MCF is maximal clot firmness that they identified in ROTEM. And they looked at XTEM. As I said, XTEM is similar to extrinsic pathway, which correlates to APTT. If XTEM was less than 45, and FIPTEM is the assay which assesses the fibrinogen levels. Fibrinogen with ROTEM assessment is called FIPTEM. If FIPTEM is less than 8 millimeter, then the Gorlinger algorithms in liver transplant suggest one has to administer 25 milligram per kg of fibrinogen concentrate. And if FIPTEM is less than, so lesser it is, bad it is. It should be more. FIPTEM should be more than 8 to 10 millimeter. If FIPTEM is less than 4 millimeter, then the dosage of fibrinogen concentrate that is recommended is 50 milligram per kg. For all my trainees, I said, if there is a bleeding patient, the dosage you should keep in mind is 70 milligram per kg. But this is based on your ROTEM assay. As a pre-op fibrinogen, if FIPTEM is less than 8, then these are the doses suggested from the study done by Gorlinger, which is called Gorlinger algorithms. And there are studies, again, in liver transplant where they have done ROTEM guided usage of fibrinogen. This was study done in 266 patients, where again they have looked at maximal clot firmness. If XTEM is less than, XTEM is similar to APTT, less than 35 millimeter, here they use prothrombin complex concentrate. And if FIPTEM, as I said, FIPTEM should be more than 10 millimeter. If it's less than 6 millimeter, they've used fibrinogen concentrate. And 58% of the patients, they had FIPTEM less than 6 millimeter. And the median dose of fibrinogen concentrate they used was 6.3 grams. And what did they find? The 38% of the patients did not need any blood transfusion if they gave a pre-op fibrinogen concentrate based on these ROTEM studies. And 85% did not need FFP, and 71% did not need platelets. So basically, all these studies are to show that you do a pre-operative ROTEM, determine that the pre-op fibrinogen levels were low, and act upon it by giving fibrinogen concentrate. You could avoid blood transfusions, avoid FFP, and avoid platelets in a significant way, is what they showed. And this was another study where they showed fibrinogen in orthotopic liver transplant. Again, they showed that there was significant reduction in the red blood. As you see, significant reduction by 54%, 70%, and 55% reduction in the administration of platelets, 70% reduction in the administration of FFP, and 54% reduction in the administration of PRBC, where they used ROTEM-based assessment and where fibrinogen assay was done and appropriate replenishment was done with fibrinogen concentrate. So we spoke about trauma. So we spoke about cardiac surgery. We spoke about liver transplant. Then we'll move to postpartum hemorrhage, which is also a dreaded complication. And as I said, third trimester, 500 milligram per deciliter should be there. And at least 50% of this should be there for hemostasis to happen. And they've shown 1 gram reduction in fibrinogen leads to 2.6-fold increase in the risk of patients having severe PPH. And to raise 1 gram of fibrinogen, the suggested dose in postpartum hemorrhage of fibrinogen is 30 milligram per kg. And this was a study in 103 patients. In one group, they used FFP, fresh frozen plasma with fibrinogen concentrate. And in another group, they used only FFP. And they showed that the FFP need was significantly less when they combined it with the use of fibrinogen concentrate as opposed to the group where only FFP was used. And pulmonary edema was significantly less because the transfusion, the need for FFP was much lesser, where fibrinogen concentrate was added as an adjunct, and the pulmonary edema also was significantly less, 24% as compared to 57%, where only FFP were given. So it goes on to show that fibrinogen concentrate should be kept in mind in patients with PPH because there is a lot of fibrinolysis that happens, and there is significant fibrinogen deficiency that tends to happen in these patients. And this was another study, retrospective observational study done in 352 pregnant patients, out of which 35%, like 124 patients, had severe PPH. And here they gave 4 units of blood with 4 units FFP with 4 grams fibrinogen concentrate as a protocol for these patients. And they could achieve hemostasis in all the patients, and survival was 99.4%. Here, as you see, instead of cryo, they had used 4 grams fibrinogen concentrate. So if you cannot remember 70 milligram, at least think 4 grams fibrinogen concentrate is something that you can give in a patient with active bleeding. If you want to replenish fibrinogen and you are awaiting the fibrinogen sort of a report, so this is something which will save a lot of time. So, and the recent consensus recommendations that came in 2019 is based on FIPTEM survey. If it is less than 4 to 6 millimeter, it means fibrinogen is very low. So fibrinogen concentrate is strongly recommended. If FIPTEM is 6 to 8 millimeter, then your fibrinogen levels is borderline, and fibrinogen concentrate could be considered in the setting of postpartum hemorrhage. But more than 14 also should be avoided, because FIPTEM more than 14 millimeter will lead to more clot formation and more procoagulation. So keep 10 millimeter. Anything less than 10, keep fibrinogen in mind. If it is more than 10, you are in a little safer zone, is what you can sort of keep in back of mind. So the conclusions of this whole fibrinogen is, so the fibrinogen concentrate is commercially available, so every trainee should know. And there is a consistent fibrinogen content. There is no fluctuation with the amount of fibrinogen present in these concentrate, because these are all recombinant synthetically prepared fibrinogen. The key advantages of this is you don't need to do ABO compatibility. We don't need to do a thawing. There's no risk of infection transmission, and there is no fluid overload or volume overload. And there is reasonable body of evidence in 5 conditions. So all the trainees remember: acquired or congenital fibrinogen deficiency, or trauma-related disseminated because we had 2 studies. We saw the 2 studies, which is the FIEST study, which came in 2023, and the US study, which showed that it is good enough and safe enough, and as a replacement for cryoprecipitate. And liver transplant, we saw a few case series. We saw the Grolinger algorithms, which are there to suggest that if pre-op fibrinogens are low, it is desirable to replenish them, and reduces the amount of transfusion that may be needed in the transplant setting. And for cardiac surgery, you have a reasonably good randomized control trial, which is the FIBRS randomized control trial. We said the fibrinogen concentrate compared to cryo was non-inferior. So it's something that it could be considered. Postpartum hemorrhage, there were 2 randomized control trials, and there are at least 4 case series, and I showed few of them, where some sort of a protocol where you give 4 grams if fibrinogen is low, or I remember 70 milligram per kg was attained hemostasis in most of the patients, and there are multiple case series which sort of substantiate this understanding. So that's about it about fibrinogen. So it is commercially available, so you could keep this. We have used in quite a few patients, and we have found a good response. And the key thing is the turnaround time is significantly less when you're using, because you don't need to wait for cryo. And I'm sure every listener would understand how difficult it is to arrange blood products in massive transfusion protocol, where you would need a lot of PRBC, a lot of FFP, a lot of cryo. So there, this can be used as an adjunct and as a synergy when you are managing such a bleeding patients. So I invite all my esteemed listeners to attend our signature conference JIGS, which is happening from 18th to 20th October. So I request you all to attend in good numbers and make it a huge success. So request all our trainees to submit their valuable work to a Journal of Acute Care, which comes out every 3 months. You can visit my website. The QR codes are there. You can scan them. So thank you. Thank you, one and all.